Good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. Saraswat for giving me the opportunity to come to Jaipur to deliver this talk. Uh, so, I bring you greetings from Sir Gangaram Hospital. Let food be thy medicine. This is what Hippocrates said about 2400 years ago. So every stage of liver disease has specific nutritional needs. So be it healthy from going from healthy liver to inflammatory stage like chronic hepatitis, fibrosis, cirrhosis, liver cancer, and end stage liver disease. Each stage will have their specific need for nutrition. And the factors which influence nutritional needs in a liver disease patient will depend on the stage of liver disease, whether he is having just fibrosis, whether he is having compensated cirrhosis, decompensated cirrhosis, and also it will depend on comorbidities, whether he has diabetes, hypertension, CKD, whether he has deficiencies like he has sarcopenia, he has osteoporosis, and what is the etiology of liver disease. All these factors will lead to deciding on the nutritional needs for the patient. So I would be covering following group of patients who have compensated cirrhosis. The goal is to prevention of decompensation and prevention of sarcopenia. Decompensated cirrhosis, the goal is now recompensation and make them have a better quality of life. Alcoholic hepatitis patients, where the goal is resolution of alcoholic hepatitis and also recompensation. ACLF, where the goal is survival. And also, I would also briefly cover NFLD and NASH patients, where the goal is prevention of progression to cirrhosis. So, in compensated cirrhosis, I would thank Dr. Pankaj Puri for making me part of this most important document of NSL on nutrition of chronic liver disease. And it is a comprehensive document which gives all aspect of nutrition. So most of my talk would be based from this. So calorie recommendation for patients with compensated cirrhosis. Cirrhosis is characterized by reduced protein synthesis and enhanced proteolysis because to fuel for gluconeogenesis. And this process of gluconeogenesis requires energy, and so consequently there's an increase in resting energy expenditure. So normal resting energy expenditure is about 1 into 24 kilocalories per kg per day. That means 24 kilocalories. But in patients with cirrhosis needs higher amount of this, so it's about 1.3 times the normal. So they would need about 32 kilocalories per kg per day. So in a normal healthy individual, if 1500 is the resting energy expenditure, 200 is the thermal effect of food, 200 is the NEAT or non-exercise activity thermogenesis, and if he's sedentary and not doing much exercise, maybe 100 he's spending in exercise. So for a cirrhotic patient who is compensated cirrhosis patient, if he is doing same level of activity, his resting energy expenditure would be higher. From 1500 it would go up to say 1700. So his caloric requirement would be higher. So so we have to take into consideration the higher caloric requirement in these patients with compensated cirrhosis. The protein requirement also goes high. The daily protein requirement in a healthy individual would be around 0.6 or 0.7 gram per kg, but the daily protein requirement in a cirrhotic patient would be about 1.2 grams per kg in absence of malnutrition and 1.5 grams per kg in presence of malnutrition if it is assessed by various modalities. The protein source, as has already been mentioned by Dr. Sunil Dadish, the vegetable protein is preferable because of low sulfur containing aromatic amino acids, which can promote hepatic encephalopathy, and high arginine and ornithine amino acids, which facilitate ammonia disposal. Also, the recommended, if the patient is taking some animal protein also, then the recommended source is either milk-based protein because they contain season and whey, also eggs and fish and chicken, but red meat has to be avoided. What about branch chain amino acid supplementation? And there have been multiple meta-analyses which have shown that supplementation with branch chain amino acid improves the event-free survival. So, if what are the events? Events such as hepatic encephalopathy, ascites. Even it has been shown that it can prevent hepatocellular carcinoma or also help in treating HCC. So, many of the societies recommend at least 12 grams per day of branch chain amino acids. For what about patients who are obese cirrhotics? So first we need to calculate their total energy expenditure, which is what I mentioned the formula 1.3 into 24 kilocalorie. That means about 32 kilocalorie per kg per day. So for a 81 kg obese cirrhotic, the total calorie requirement would be 2600. Now we have to give him some calorie deficit. So we have to reduce by 500 calorie. So 2600 minus 500, that means his dietary prescription should be about 2100 calories. And once we have decided about 2100 calories, the composition should be that carbohydrate should be 50%, fat should be approximately 30%, and protein requirement as approximately 20%, which would be approximately 1.2 to 1.5 grams per kg of the body weight. Now, recommendations for decompensated cirrhosis. The patients with decompensated cirrhosis, when we are calculating their resting energy or the total energy expenditure, we have to do it based on their dry weight, and we have to correct for ascites or edema. So, how to correct that? We can use the pre-ascitic weight if that is available, or you can calculate using the ideal body weight based on height and ideal BMI. For Indian population, the ideal BMI would be between 18 to 23. Or you can use the paracentesis weight, or you can correct it empirically by subtracting a percentage. Like for mild ascites, we have to reduce by 5%, for moderate ascites 10%, and for severe ascites 15%. And if the patient additionally has pedal edema, we have to reduce by 5%. So, according to the INASL guidelines, the optimal recommended daily calorie and protein requirement in patients with cirrhosis and both compensated and decompensated, the calorie requirement should be approximately 35 kilocalories, protein 1.5 to 1.2 to 1.5 kilogram, and multiple small frequent meals, at least 4 to 6 hourly, have to be given with complex carbohydrate, bedtime snacks, and protein-rich breakfast has to be recommended. So most of the myths have been busted by Dr. Sunil Dadesh. So one of the myths is that patients with cirrhosis should consume low fat. But this is a myth, and patients of cirrhosis have poor glycogen reserve, and hence they require more fat so that they don't have hypoglycemia, and they spare their muscle breakdown. So please do not restrict any fat in patients with cirrhosis. Up to 30% of calories should come from fat, and we should increase their monounsaturated fatty acid and polyunsaturated fatty acids, and balanced omega-6 to omega-3 ratio should be there. We have to reduce their omega-6 vegetable oils, processed snacks, and fried foods, and increase their omega-3, that is fat coming from fatty fish, flax seeds, and walnuts in the diet. And even saturated fat may not be bad for patients with cirrhosis. There has been some evidence that dietary saturated fatty acid downregulates the cyclooxygenase and tumor necrosis factors in patients with alcoholic associated liver disease. So I usually advise my decompensated cirrhotic patients to have ghee laga ke they can have aloo ka paratha, and they become very happy because saturated fat is not restricted. It is more deleterious for patients who are having cardiovascular disease, but patients with decompensated cirrhosis, patients who they need actually saturated fat. Salt restriction for ascites. Cirrhosis induces a positive sodium balance due to impaired renal sodium excretion. So salt restriction is the mainstay of ascites management. However, major issues with salt restriction is that there is a higher risk of malnutrition due to impaired palatability. So a strict salt restriction should not be advised because it is associated with higher incidence of hyponatremia. So moderate salt restriction up to 5 to 6 grams is better, which and we can take care of ascites by increasing the dose of diuretics. What about the dietary prescription in patients with alcoholic hepatitis? Among all the etiologies of chronic liver disease, malnutrition is much more common in patients with alcoholic liver disease, and almost all patients who are admitted with alcoholic hepatitis are malnourished, and because of that, these patients have got higher mortality. And the combination of malnutrition, infection, and organ failure determines the outcome of patients with alcoholic hepatitis. So, the first and most important step in the management of alcoholic hepatitis is abstinence from alcohol and then nutrition supplement. So, what are the causes of malnutrition in alcoholic hepatitis? They are multifactorial. They have decreased protein intake, increased malabsorption. They have mechanical issues due to ascites and increased intestinal permeability, and they have decreased appetite. So all these factors contribute to malnutrition. And all alcoholic hepatitis patients need micronutrient supplements with the thiamine, vitamin B6, pyridoxine, vitamin B12, folate, vitamin A, vitamin C, zinc, and magnesium. So all admitted patients with alcoholic hepatitis should be supplemented with these using the standard doses. Alcoholic hepatitis patients need higher caloric intake, and the multiple studies have shown that the Mendel Health study in alcoholic hepatitis showed that these patients have higher mortality, more than 80% mortality, if they were calorie restricted to less than 1000 calorie compared to those who were consuming to 3000 calorie. And the risk of mortality varies inversely with the daily calorie consumption. So recommended is 30 to 40 kilocalorie per kg per day. What about in ACLF patients where the goal is actually survival? The ACLF patients who are admitted in ICU may need very early tube feeding because they have a net catabolic state due to sepsis, due to organ failure. So they are also having various symptoms like vomiting, GI bleeding, SBP, ileus, and they are kept waiting for hours because they have to undergo various procedures, CT scans, and endoscopy. So NJ, nasojejunal or nasogastric feeding, both can be used. The caloric intake should be much higher, 30 to 40 kilocalorie per kg per day, and protein intake up to 1.5 grams per kg per day. Briefly about NAFLD and NASH. The most important treatment for NASH is weight reduction, because with the weight reduction, there's a resolution of NASH, there is a resolution of fibrosis and steatosis. So, how do we reduce weight? There are lifestyle measures like diet and exercise, which we can expect a 5% weight loss. But exercise alone is not enough, and we have to always combine it with diet. But if all these measures fail, then we have to go for drug therapies like GLP-1 agonists are now upcoming drugs, or endoscopic therapy, bariatric surgery. But the first step towards counseling of these patients is their dietary counseling. So we have to assess what is the calorie consumption per day, starting from their morning tea to their dinner time. We have to calculate how much calories they are consuming. So this is the example of one patient who came to me, and when we calculated their calorie consumption, he was consuming about 2800 calories per day, which was way too high for a sedentary individual. He should have been consuming approximately 2200 or 2300 calories, but he was consuming 500 calories extra every day, which was contributing to his obesity. So we have to reduce weight, we have to cut down the daily calories. And this is the basic principle of weight loss, is that you have to consume less calories than what you are burning. So try for a deficit of around 500 to 1000 kilocalories per day. And 1 kg of body weight is approximately equal to about 7700 calories. So if you reduce the calorie intake by just 500 calories per day, you can reduce the weight of by 1 kg even in 2 weeks time. So this strategy of continuous energy restriction or daily calorie restriction is simple. And how do you achieve this daily calorie restriction? You can reduce the portion size. You can ask him to take meal in smaller plates so that he consumes less amount of food. Then you can ask him to choose a low calorie dense food. So for example, if he eats even one third of burger, that would be 300 calorie, and he still would be hungry. But if he consumes that same 300 calories in fruits and vegetables, he would feel full. And then we can advise some of the patients who have smartphone that they can track their caloric intake on day-to-day basis. Although most people are not able to do it, but even if 10% are able to do, we can make a big change in that. So this among all these three things, the choosing a low calorie dense food is most important. So in the patients which I just mentioned, if he just instead of taking the normal lunch he was taking, if he replaces it with a plate of salad, he would consuming 500 kilocalories less than what he was consuming, and he would consume approximately 2300 calories, which would actually lead to weight loss in this patient. So we would be able to achieve 12 kg weight loss by just simple one change in the his lunch. And the alternative to daily calorie restriction is the intermittent fasting. And there are many types like alternate day fasting, 5-2 diet, which you can find from anywhere. And we can expect 3 to 8% weight loss with intermittent fasting. And some studies have shown that intermittent fasting can lead to reduction in blood pressure, also improvement in dyslipidemia, and improvement in insulin resistance. So, dietary recommendation for NASH: hypocaloric diet, at least 500 to 1000 kilocalorie reduction; low carbohydrate diet, 50% from carbs, and less than 5% from added sugar; 30% from fat, with less than 10% from saturated fat; 20% from protein. Avoid fructose containing diet; substitute saturated fatty acids with the PUFAs and NUFAs; prefer oil with more health benefits, and increase soy content, increase fiber, and ensure adherence to whatever diet he chooses. So, take home points, ladies and gentlemen. For compensated cirrhotic patients, the total caloric intake has to be increased to about 32 kilocalories per kg per day. Protein intake should be 1.2 grams per kg if no malnutrition, or 1.5 grams per kg if there's malnutrition. And in obese cirrhotic patient, there should be a caloric deficit of 500 kilocalories. For decompensated cirrhosis, increase the caloric intake even further up to 35 kilocalorie per day, 1.5 grams of protein. Do not restrict fat, but moderate restriction of salt intake. For alcoholic hepatitis patients, increase their caloric intake even further up to 40 kilocalories per kg, and focus on micronutrients because they have so much of deficiencies. For ACLF patients who are admitted, institute early tube feeding because they have very poor appetite, and they have to wait for various procedures. And for NAFLD and NASH patients, reduce the calorie intake by at least 500 to 1000 kilocalories per day, and reduce the carbohydrate intake to 50%. With this, I would like to invite you to our, which we are starting in Asal clinics on HCC at multiple cities. These are the dates. You can get the details and you can register under the patronship of Dr. Subrat Acharya and Dr. S.P. Singh and Dr. Ajay Doseja. I invite you to any of these cities for a simple evening symposium on HCC. Thank you for your patient hearing.